At the onset, I would like to thank Mr. Kamal Bhawa, General Manager, Cadila Pharmaceuticals, and Mr. Sudeep Chakravarti for giving me such a splendid opportunity to be a part of this noble, innovative forum, IAMICON. Respected dignitaries on the dais, Dr. Nilima Chafikar Madam, who is the HOD from Dr. Vasant Pawar Medical College in Nashik, Adgaon, my senior colleagues, eminent leading practitioners sitting out here, young colleagues out here, my heart warmly big namaste to you all. And my batchmate Vivek Bhagat, I'm privileged that he is with me today. I'm really privileged. I'm happy to be in this 16th fastest growing city in India. A city of pilgrimage, a land surrounded by Shirdi, Trimbakeshwar and Saptashringi. And last not the least, कहते हैं यहाँ के लोगों में नशा होता है. Asking some few basic questions which I am definite everybody in your life must have come across these questions in your life. This is Vikas Bharti, 30 years old male, non-hypertensive, non-diabetes, non-smoker, no significant family history, got married around 10 days back. What is his chances of getting heart attack? 2 to 5%, 5 to 25%, 25 to 30% or none of the above? What do you feel? None of the above? He's got recently married. Now I think it's good. No? Let's see. He is Siddharth Roy Kapoor, his second marriage to Vidya Balan. He's got mild truncal obesity, non-hypertensive, non-diabetic, no sick disease, smoker, sedentary lifestyle, alcoholic, no aspirin, no anti-cholesterol agent. What do you think? What could be for a period of last 10 years? There are different components of metabolic syndrome. There are something like hypertension greater than 140/90, triglycerides where triglycerides is greater than 150, HDL is less than 35, obesity. When you talk about obesity, three factors we take into consideration: body mass index, waist circumference, waist to hip ratio, impaired glucose tolerance. And this definition of basically metabolic syndrome changes from country to country. There is something called as International Diabetic Federation, there is something called WHO, there is something called as National Cholesterol Education Program. For WHO, they think microalbuminuria. I am emphasizing this point because abdominal obesity, India, if you see every female in India, they'll have nice tummy. You go to China, you go to abroad, they have got flat tummy. That is because our diet is so rich. Obesity. When you talk about obesity, what is important? The body mass index formula is very tedious job calculation. The best thing is your waist circumference. If you measure the waist, very kamar 36 inches, very kamar 38 inches. That is a basic, important thing to come to think. A very interesting article was given in JAPI 2009 stating the consensus statement for diagnosis of obesity, abdominal adiposity, metabolic syndrome for Asian Indian, and it recommended physical, medical and surgical treatment, and according to which Indians have more cardiovascular disease, dyslipidemia at lower waist circumference as compared to anybody else. I want to diabetes is growing globally and it's a big burden. Already around 246 million people are affected. By 2025, around 380 million people will be affected. India is already a capital. Diabetes causes obesity, everybody knows. Anti-diabetic drug causes obesity, everybody knows. Obesity causes diabetes, everybody knows. So it's a viscous phenomenon. Everything, the ball is rolling and one factor is predisposing to the other factor. India is a capital and around 30 to 65% of the adult urban Indians are either overweight, obese or have abdominal adiposity, hence rising the incidence of obesity related comorbidity. That means if this hall has got 200 people, 60 people out here are either diabetic or hypertensive or dyslipidemic or obese. The chances of 60 people in this hall is very high of dying, very high. 60 people dying in this hall, that means in Nashik you compare how many people will be dying. So that's a big volume, that's a real big volume. A very interesting article was published by American Journal of Management Care 2004. What it did is that it basically accommodated around 137 cohort of people, and it segregated them into how many people have diabetes, how many people have diabetes and lipids, how many people have diabetes and hypertension, how many people have all the three. And a very staggering data came in front that 56% of the people had diabetes also, hypertension also, and dyslipidemia. Then that means they are a bomb. That means more than 50% of the people are having all of them. That means India is not only capital for diabetes, it's also capital for hypertension, dyslipidemia, and metabolic syndrome. 30% of the death by 2010. Cardiovascular disease, if you take majority of the factors, which is coronary artery disease, is around 69% of the primary event, and secondary events are around 31%. This is again a very interesting slide. Basically, it shows which disease is ranked high with respect to mortality, and it is evident that the heart disease and cardiovascular disease is still number one in spite of your cancer or accident or anything. So when I talk about cardiometabolic risk, what I mean is that the global cardiometabolic risk represents the overall risk of developing type 2 diabetes and or cardiovascular disease, which could be something like myocardial infarct or a stroke, which is due to a cluster of modified risk factors. We have understood for decades hypertension, elevated blood glucose, smoking, all this causing cardiovascular disease. This is not something new of Shankar, That is what has happened. So there are many questions which is tickling me as of now. Can we increase the life expectancy? If yes, then how? Can abdominal obesity, when I talk about abdominal obesity, I mean Indians. Can it lead to diabetes mellitus? Can abdominal obesity increase the risk of coronary heart disease? Does abdominal obesity increase the risk of cardiovascular disease? Is there any risk for cardiovascular disease in spite of statin? Or better pill or no pill? Or many pill with lot of bill? In this economic slowdown era, bill really kills, वो कहते हैं ना कि जब डॉक्टर किसी की जान बचाता है तो वो भगवान का रूप होता है, जब पैसा मांगता है तो शैतान का रूप. It's something like this. So let me take you to a series of trials to prove my point. It will help me get the answer of whatever questions I had asked or I had put or it has come to my mind. Because today's world, we believe in evidence. There was an analysis of HOPE. The whole decade we are talking about HOPE 1, HOPE 2, now HOPE 3 is there. It is nothing but heart output protection evaluation study, which was done for the effect of abdominal obesity with respect to waist circumference on the risk of all-cause or cardiovascular death or MI in more than 6,000 males and more than 2,000 females. And it shows that there was a direct relation between the obesity and the chances of getting MI or death. It increased with increasing tertile for waist circumference. Then the thing is that can abdominal obesity cause diabetes mellitus? There was a nurse's heart study which had a cohort of more than 43,000 females between the age group of 40 to 50 between the year 1984 to 1994 in USA, and it found that as your waist circumference increases, your chances of getting diabetes mellitus also increases. Can abdominal obesity increase the risk of coronary heart disease? The same study, the females were followed up for 8 years, and they found that as your abdominal obesity increases, your chances of getting coronary heart disease also increases. So I am getting answer to all my questions. This was a very last study about statin. Statin has revolutionized and ruled for last 2 decades in the treatment of patients with cardiovascular disease. Are statins enough to prevent cardiovascular events? The big question. Statin दिया में सब कुछ हो गया क्या? Patient बच सकता है क्या? Simple approach. The Medical Research Council and the British Heart Federation Heart Protection Study was one of the landmark trials that established the place of statin in the management of hypercholesterolemia. A population of more than 20,000 males with cardiovascular risk were given a dose of simvastatin 20 mg, and it was observed that the cardiovascular event dropped down drastically by around 20%. That was a big thing. That means there are some other factors which we are not looking into. Maybe we are not control the triglycerides. Maybe we are not looking into the HDL factors. Maybe there could be some other factors which could have taken role or which could have taken place. We have not seen into that. So patients with metabolic syndrome are 3.5 times more likely to die because of cardiovascular disease as compared to normal people. And so what are the risk factors which could lead to MI? It could be stress. The stress was basically classified into Chinta, Chinta, Chita, Sama. That means for all disease, Chinta is the reason. If you read cancer, stress. MR, stress. Diabetes, stress. Any disease in textbook you study, it is stress. So what Interheart study did is that it accommodated all the risk factors and it said that there are 9 major risk factors. One is smoking, other is lipoprotein A and B, the third is hypertension, diabetes, abdominal obesity, psychological factor, lack of consumption of fruits and vegetables, lack of exercise, excessive increased intake of alcohol. And it found that if these factors are there, then your chances of getting heart attack is 90%. 90% could be a stress. For you staying in Bombay could be a stress. So stress, what is the definition of stress? There are so many things. They say that alcohol causes problem. The latest study says that a person who is alcoholic, his chance of getting heart attack is less as compared to a person who is alcoholic. So साला दारू पियो तो problem, नहीं पियो तो problem. तो जियो तो कैसे जियो? You know, that's, and where am I giving the lecture? I don't want to teach you because I am giving a lecture in the capital of wine. You know, that's how it is, you know. All these factors can be controlled. I can control. ISD risk doubles at the age of 55. Because there was a very other interesting study, that is prospective study. It basically is called a PURE study, P-U-R-E, that is nothing but prospective urban rural epidemiological studies. It basically examined the impact of social influence on chronic non-communicable diseases in low, middle and high income group. It basically was done in around 17 countries with 528 urban and rural populations with a population of more than 1.5 lakh people. And what it did is that it basically categorized the patient with cardiovascular disease and stroke consuming more than 4 major medication were categorized in 4 groups: high income group, upper mid income group, lower mid income group and low income group. And these data were compared with rural and urban population, and it was found that the actual uses of drug was very low in low income group in rural and urban population. That means they can't afford the drug. They took drug only for 1 month or 2 months. But doctor did the right thing by prescribing them all the 4 medications. But they could not continue for a long time because of मैं पेट देखूं, बच्चे देखूं कि मैं अपने आप को देखूं. This is a hardcore reality of life. So the problem zone is that greater than 90% of the individual over the age of 50 years have elevated LDL, high blood pressure, and at least one traditional risk factor. You can't say कि मेरे को risk factor ही नहीं है यार बॉस, मैं teetotaler है, मुझे कुछ नहीं होएगा. There is a risk factor. Age is a risk factor. So there is one risk factor which is going and which nobody can control. Cardiovascular disease is preventable through risk management. We say that in spite of statin, in spite of anti-diabetic drug, anti-hypertensive drug, anti-platelet, anti-obesity drugs, cardiovascular disease are still on the rise. So while our focus is applying cardiovascular prevention in high-risk individual, most cardiovascular events occur in average level of risk. That means if I say tomorrow you're going to die, you say, doctor, tell me what to take. I'll take all the tablets. But if I tell you, अरे नहीं, chances नहीं यार, मरेगा नहीं यार, कुछ नहीं, हो सकता है बाद में 10 साल के बाद या 20 साल के बाद. So these are the people, in between. They say match is not over till the last ball is bowled. And you get casual and you lose the match. It's similarly like this, we get casual with, moderate risk or average level of risk, and we get casual. Risk reduction by individual intervention, this has been shown for ages. We said that blood pressure is there, take anti-hypertensive tablet, the chances of you getting CS, coronary heart disease will be less, your chances of you getting stroke will decrease. You have dyslipidemia, take drug, 20% reduction is there. But the thing is that treating a risk factor alone is not adequate, and this has been shown in a lot of journals and a lot of trials. Only one factor if you treat, it is not going to help you. Multiple pill or combination therapy role in risk reduction has been shown over decades in many trials and evaluated the impact of population and high-risk strategies for the primary prevention of cardiovascular disease. That means if I take anti-hypertensive tablet, give the patient anti-hypertensive and anti-triglyceride agent, individually they will cause 10% reduction, but combination will cause 40% reduction. That is superb. Very good. So I'll add 2 drugs. Why should I give 1 drug? I should give 2 drugs. This was a man behind Polypill. Basically, he is nothing but, his name is Walden's Law. He was a man who was first, made Polypill he used three antihypertensive agent at a lower doses, folic acid, antiplatelet agent, anti-cholesterol agent, and he found there was reduction of around 90% of the risk. And the same theory was followed by Salim Yusuf in our polypill study, and it found that when he used the same ingredients in a modified way, the relative risk reduction was around 75%, and that was significant. That means not only cardiovascular risk reduction but also mortality reduction has been documented. So at least one conclusion as of now of my presentation I draw, that multifactorial risk approach is much better than individual risk approach. You all agree with me? Multifactorial risk approach is much better than individual risk approach. You all agree with me? It has been observed that the 1/3 of the patients are non-compliant within 1 month of treatment. Multiple factors cause non-compliance like number of pill, chronic condition, cost, complexity of the treatment, and it's well known fact that outcome is poorer in non-compliant patient. Poor outcome in a non-compliant patient. So the need of the hour has arrived for polypill, and that's not polypill, it's our Polycap by Cadila. Cadila has gone through a huge journey for more than 10 years to bring a novel molecule, Polycap. India is proud of Zero. Zero was discovered in India, but I am proud of Polycap because Polycap, all studies were done in India, and it's the only trial which was done in India was TIPS, the Indian Polycap study or polypill study number 1, the Indian polypill study number 2. Now they have done Indian polypill study number 3. They are going into 3 with already 1,000 recruits. So we should be proud of this because it's an Indian molecule. If you break a gelatin capsule of polypill or Polycap, we get 3 antihypertensive drugs, basically hydrochlorothiazide 12.5, used as a diuretic, atenolol used as an antihypertensive agent of 50 mg, ramipil 5 mg, ACE inhibitor, 1 lipid lowering agent, simvastatin at 20 mg, and antilipid agent like acetyl salicylic acid at 100 mg. So this is the combination, everything is combined together and given 1 tablet in the morning. Sorry, I think it's going backwards. So where are the patients who can benefit from Polycap? Who are the patients? The pre-existing disease like heart disease who have stroke, who has peripheral artery disease, who has got diabetes mellitus, they are the patients who will be benefited. Those with pre-existing disease, those without pre-existing disease but their age is greater than 55 years old, then they should be given Polycap. A lot of hard work. The excipient has to be chosen carefully so that it is compatible with all the drugs and the size of the drug does not become large enough. Each ingredient must be bioequivalent when compared with individual formulation. Hence, pharmacokinetic study needs to be conducted. A large efficacy study with many groups is needed so that the effect of all the components are classified and drug interactions are ruled out. This is only achieved with multiple arm study and pharmacokinetic study, and that was done by TIPS. The bioavailability of the drug when given in Polycap as those given versus those given individually are compared, and Polycap really matched it equally, in fact much better as compared to drug. The Polycap study was nothing but a randomized double-blind comparative trial. More than 50 centers in India, more than 22,000 people were taken into consideration without cardiovascular disease between the age group of 45 to 85, and with one cardiovascular risk factor was also taken. Suppose diabetes is there, that is also taken, and active treatment was given for around 12 weeks, and follow-up was done for around 16 weeks. The impact on blood pressure, heart rate, lipid and urine thromboxane D2 inhibition, that is the effect of antiplatelet effect, was done, and safety and tolerability was done. Basically one arm was given only aspirin, other arm was given simvastatin, other one was thiazide, other arm was given combination drug, arm was given 3 antihypertensive, other arm was given combination of other, and one arm was given only Polycap. So all the arms were studied and it was seen how does the molecule goes. This is just to show that patient with one risk factor, diabetes, was also taken into consideration. There were around 696 diabetic patients also, and the result was really good. If you give one lipid lowering agent, there is a drop in systolic and diastolic. But if you give Polycap, it was much more significant as compared to 3 BP lowering agent. And antiplatelet effect or efficacy was also maintained with Polycap. So the tolerability and of the Polycap was similar to that of other treatment, with no evidence of increasing intolerability with increasing number of active component in one pill. There was Polypill 2 trial or Polycap 2 trial. It is also called a TIPS 2 clinical trial. It is nothing but a randomized double-blind control trial. The efficacy and safety of low-strength Polycap versus double doses of low-strength Polycap with potassium supplement was conducted in a patient with stable cardiovascular disease or ischemic heart disease, and it was found that when 2 tablets of Polycap was given, the reduction in blood pressure was much more as compared to 1 tablet, and the reduction in LDL was much better as compared to 1 tablet of Polycap, but heart rate reduction was near about the same. So it is observed that the relative risk reduction with double strength of Polycap was better than a single strength of Polycap. The relative risk reduction with double strength Polycap was much better than single strength Polycap. A lot of lives have been changed. Basically 4 out of 5 deaths in cardiovascular disease occur in a developing country. Millions of patients at risk throughout the world. Out of that, 50 millions of stroke, 50 millions of ischemic heart disease, and 25 millions are in India. So Polycap has a place in therapy. A lot of lives can be saved with Polycap because Polycap has shown efficacy and safety in 2 large randomized trials, and market trends have also shown increased acceptance to the combination of drug as compared to single molecule. And what to tell more than this? The latest edition of Harrison has a chapter on Polypill, and I was a paper setter for the previous year and I had given a short note on Polypill. And the whole world is talking about Polypill, and it's an Indian baby, and we are only not talking about Polypill. The ESC, the European Society of Cardiology and Hypertension, have mentioned in their guideline in management of arterial hypertension about the positives of TIPS trial. They have also accepted, and they have said that if you use multiple drug and it is useful, then it is much better than giving a single drug. The WHO, there is a target by 25 by 25. WHO has announced that by 25, you should 2025, the target is to reduce the non-communicable disease mortality. And the cardiovascular disease secondary prevention with fixed dose combination therapy has been deemed as the best by WHO and organizations such as NCD Alliance, as it has been noticed that more than half the patients with prior ischemic heart disease and stroke receive no secondary medication. That means the role is that Polypill should be so sasta that the aim is that it should be less than $1 per month. That means less than 2 rupees per day. Can you get a simvastatin at less than 2 rupees or a Aten at less than 2 rupees or any other thing? But you are getting everything in less than 2 rupees. That is the aim. Demand is more effective single approach towards enhancing adherence. Fixed dose combination therapy reduces the dose demand. That means all the organizations in the world are talking about usage of multiple drugs. The ESC 213 guidelines have also come. They are also advocating the use of Polypill or Polycap. There are different recommendations all over the world. The American government is talking about, the New Zealand government is talking about, you name it in the world, and everybody, the whole organization, allied associations have given their recommendation for use of Polycap. Everybody is using Polycap, and everybody has given their endorsement for the use of Polycap. They say swasthasya swasthya rakshanam atharuvyadi parimokshanam. It was spoken by Charak. The aim of traditional medicine according to Charak is to maintain a healthy person and relieve his suffering. Yoga, exercise is very important, but you should not be casual. That is not the only way to prevent the things. People have been doing yoga and still they have died. There was an interesting article on 14 November 2012 in Times of India, which issued the new guideline issued by American College of Cardiology and American Heart Association. It mentions that 4 category people should use statin immediately without any delay. The first is those with cardiovascular disease. Second is those with ILD greater than 190. Third is those with type 2 diabetes and the age between 40 to 75. And the last is those with estimated 10-year risk of 7.5% should be immediately put. That means it is advocating the use of statin immediately. That means given a choice at the age of 50, if I want to take one drug, I will not take vitamin, I will take statins. There's no compromise for that. But Polycap is used where? For high risk primary patient with age greater than 55 years and all secondary patients. That means who have got ischemic heart disease, who's got any problem with stroke or anything. For them, apart from Polycap, yoga is also important. I'm not saying yoga is not important, exercise is not important. But yoga and exercise are only treatment for primary prevention. But for secondary prevention and high risk primary, these are important. Any questions?
Did they try adding metformin to Polycap?
Metformin they have not tried because the thing is that your question is a very interesting question because you can add a lot of drugs. I can have any drug combination, but the important thing is that whenever you talk about Polycap or atorvastatin was not used in simvastatin, I would have expected this question. Why simvastatin? Because atorvastatin ka life is much delayed as compared to simvastatin. Simvastatin matches with all the pharmacokinetics. That's it.
The two types pill, especially in the aging format, prevent from early surge of blood pressure and
Yeah, I'm going to say
early morning deaths.
Early morning deaths, even one pill can definitely help, but two pill will definitely help you much more reduction in blood pressure as compared to. I think you're talking about something like telmisartan early morning surge. So much better.
This pill can be
Yes.
taken twice a day, and night dose will be superior than.
I don't agree with you. This pill can't be taken twice a day. It has to be taken 2 tablets if you want to take only once times a day. That means because the pharmacokinetic will differ. If you are taking in the morning, I think ideal time is morning, so you are able to take 2 tablets in the morning.